Very good. Thank you. So I'm Jerry Lee. I'm the other Dr. Lee. I just started last month. So, like I said, I'm just trying to meet everyone, get a sense of the place. My primary interest is it's asthma, immunodeficiency, also medical education. And so, any of you guys want to just kind of, I have a med peds background too. So, like I said, if you want any kind of discussions about allergy, med peds, that sort of thing, you have my number. You can just call the Gray Street office. They can get a hold of me. Also, my email is up there too, Gerald Lee at louisville.edu. So please, anything, like I said, I'm very motivated to get started, that sort of thing. And we want the division to grow. So if you find like another Dr. Lee with 3 E's, we can hire that person, and we'll just continue to keep it going. All right, so let's let her rip. So Tal gave you a great talk about allergy and sinusitis. So let's just talk about one of the main interventions we use to target allergic disease, and that is immunotherapy. So is that okay? Let's give you a little background on allergy, just to kind of talk about what we do. So allergy, the modern era of immunology is it's basically the 20th century, and this osteopediatrician Baron Clemens I don't know Austrian, I'm sorry, Percat. He basically coined that phrase in 1906, and it's a combination of 2 Greek roots and other and work. So it implies the altered bioreactivity to what you think is like a normally innocuous or non-harmful protein of some sort. And so our goal with immunotherapy is to kind of restore not the other work but normal work, right? How we just ignore something irrelevant like birch pollen. Oh, is it working? No? Oh, I was so excited. Jeez. All right. So, he coined the phrase, and he's now on a coin. The Austrian Mint commemorated this in 2010 by putting him on the 50 euro piece. You can buy this, and you could, have a piece of allergy history for posterity. If you're not nervous about the whole euro currency crisis, just think about it, right? This could be very important one day. So what do we do? I just wanted to briefly go over this, just kind of introduce ourselves. And we kind of do our things in 2 domains. The first domain is that we work with the primary care pediatrician to assist with treatment management of some common disorders. And the ones that we'll talk about that later. And then we have specified testing for certain conditions that we kind of have special expertise in. So the conditions that you guys are on the front lines of, that we kind of play more of an ancillary role, is the conditions that Tal mentioned, rhinitis, sinusitis, asthma, particularly those that have an allergic component or some sort of kind of more greater severity. And then less relevant to medicine would be like eczema, contact dermatitis, especially occupational exposure is either domain of us or dermatology. The other thing that the other kind of domain that we kind of participate in is kind of definitive diagnosis of certain conditions, and that would be mostly food or drug exposures. I'm going to talk about immune deficiency today, also anaphylaxis, urticaria, angioedema. And then some other things like stinging insect hypersensitivity, eosinophilic esophagitis, which is becoming more prevalent nowadays, and then kind of more more rare lung conditions. Well, not as rare. Allergic bronchopulmonary aspergillosis, hypersensitivity pneumonitis, like bird fanciers and all that stuff. Aspirin sensitivity and occupational asthma. But let's start with this is my. I'm sorry, this is my wrong. Let's talk about immunotherapy first, and then we'll talk about that. Sorry, I didn't change the slide there. Okay, so you're in your office, and this lady comes in, and she just came out of the hospital. She had an anaphylactic reaction to an insect sting. She was basically got a brand new house. Interest rates are really low now. You like what, 4% or something like that. It's amazing. It makes me feel regretful. But anyways, and she gets stung by a yellow jacket. generalized hives, swelling, wheezing, lightheadedness, pretty severe reaction. She had to get 2 rounds of epi, had to stay overnight, and she's living here. This is her environment. She cannot avoid this. She just put down the the down payment of the 30-year, fixed rate, right? So how are we going to help this person? What can we do? Should she stay indoors? I mean, does she, should she like bomb the entire surrounding area with insecticide? What can we do for this lady? Well, one of my objectives here is just kind of talk about the role of immunotherapy of patients like this, and just in general in allergic disease. And I really kind of want to go over who are the patients who qualify with this type of therapy? How do we think it works? One thing you learn about fellowship is that you kind of think you know how things work, and then you learn more, and then you don't realize that there's a lot of stuff we don't know. But like I said, we're kind of continuing to develop some of these things. And then, we're just kind of, there's some stuff down the pipeline that I just want to mention briefly. So this is like the key points here. And so, immunotherapy also is a 20th century invention. Basically, I said, 1906 for coining the term. 1911 is when immunotherapy was first started. It was 2 physicians, a doctor and Dr. Freeman, who published a landmark Lancet article in 1911. And basically, they had patients who had demonstrated allergy to Timothy grass pollen. Basically, they just shoot into the eye. As you can imagine, it'd make anyone's eyes water. But these people were particularly allergic, and so they had a conjunctival flare and swelling, and that sort of thing. And so what they did is they immunized them against Timothy grass pollen. And we'll talk a little bit about the procedure for that. And there was a 100-fold improvement on the tolerance of grass pollen after going through this immunization. So this kind of was the first proof of concept that we can actually retool the immune system to kind of restore normal work, right? Restore a regular response to, grass, Timothy grass, which is usually, it's not going to, cause you to, get pneumonia or something like that, all right? And so what is the rationale to do immunotherapy? What does immunotherapy do for certain patients? And I would say there's kind of like 4 main domains that we're trying to do. The first one is we're actually trying to obviously reduce symptoms. That if you get exposed to that antigen, instead of having an inappropriate response, you're going to just have a regular or more appropriate or a tolerant response. Number 2 would be reduction in medications. Right? We basically try to blunt the response by continued exposure. We try to shut down gene transcription with steroids. We block histamine, so the mast cells are releasing tons of histamine. We're trying to block the receptors to that. But why not target the underlying problem? The third one is the lady I mentioned here. So, this is a lady who could have died. She could have died after that bee sting. And so if there is a therapy that could potentially save this person's life the next time they get stung, I think that therapy should be offered to that patient. And the last one is there is some evidence to suggest that we can actually modify the natural history of certain allergic diseases. And let's just talk about that for a second. So the first thing we'll start on is what I was talking about is symptoms and medications. And so what I'm showing here is basically a summary of 2 meta-analyses, one looking at sublingual, so that's not the shot per se, that's more like the oral form that's mostly in Europe right now. It's not FDA approved in the United States. The other one is SCs, the subcutaneous form of immunotherapy. And basically, we're talking about, thousands of patients with placebo arms and treatment arms, and basically the p-value is, it's like way low. There is clearly a difference, and so this scale here is an attempt to standardize the mean difference between placebo and the immunotherapy group, and for both sublingual and subcutaneous immunotherapy, if you look at either symptoms or reduction in medication, multiple studies have shown that this therapy does seem to reduce both of those outcomes. Now, when I talk about modifying the natural history of allergy, it's nice to get some perspective of what happened to a lot of these patients. And we think a lot of these Later conditions, kind of the origins start very early in life. You might have a impaired barrier, eczema, a different skin type where you might be exposed to different antigens in a different way, where your first contact might be on the skin rather inhaled or ingested. A lot of these patients may develop food allergies, inappropriate responses to food, and then that sometimes might set the stage for them to develop rhinitis symptoms, which Tao mentioned. And we know that there is a relationship with the development of rhinitis and a subset of these patients getting not only nasal inflammation but lower airway inflammation, so asthma. All right, so there has been kind of a very, very well-quoted study, the PAT study, where they basically put patients on 3 years of immunotherapy, asking the question, can we modify the atopic march? Are you basically doomed to have, I'm not saying every 100% get asthma, but if these patients were more likely to get asthma, is there anything we can do about it? And so basically they enrolled a sizable pediatric population, about 70 patients in each arm, about mean age of 10. They got 3 years of shots, and then they did follow-up up to 10 years. The 10-year data, I think, was published in, 2007, right? And basically, when you look at new onset asthma in the treatment arm versus the placebo arm, there's a clear difference that, by giving 3 years of immunotherapy, right, I mean, they only, this is 10 years out, the 3 years of immunotherapy they got early in life was actually able to modify their development of asthma later, all right? Some of the other studies are kind of more retrospective or open style. This is kind of like the double-blind, placebo-controlled level of evidence. But there is some evidence that even sublingual routes, other than the allergy shot routes, can have some sort of significant difference in the two arms. Let's talk about other allergies too. So there's kind of seems to be a suggestion that if you're allergic to one pollen, you're kind of more likely to develop other sensitivities later in life. So asking the same question, again, a lot of these are retrospective data. Some of them do have kind of more like randomized control trial type designs, but at least the retrospective data seems to suggest that if you looked at new onset allergens in the patient actually getting immunotherapy, either 3 to 7 years, or placebo arms, there is also a significant difference there as well. So we're able to kind of actually retrain the immune system to do some of these things. So let's just kind of think about who are we targeting this therapy for, and this is kind of comes from the practice parameter that was published in 2010, and we think about the major patients who would qualify for this. The first one is that you have to be allergic, right? That makes sense, right? And so we would usually demonstrate this based on skin tests or blood testing, and then you probably need to have some sort of certain criteria of who would benefit the most, and some of the features that would be in line with this is the patient consenting to the therapy, right? It requires a fair amount of adherence to show up to these visits, and I'll talk about it a little later. Patients who either don't respond to medicine or on a fair amount of medicine, patients who are unable to avoid the whatever's causing their symptoms, and then, like I said, I did talk about maybe some evidence that we could modify the natural history of allergic disease. And now, the one that is, at least in my mind, more of a slam dunk is patients who've had anaphylactic or systemic reactions to Hymenoptera or any insect venom, bees, wasps, whatever. And that is because these reactions are unpredictable. One reaction does not predict the other. And also, this is a potentially life-threatening condition. And so, this is a therapy that could potentially save their life the next time they get their next sting. Now, this is kind of less relevant to medicine, but there is this kind of arbitrary cutoff at 16 years of age, where if you have a systemic reaction, which is defined as symptoms outside of the sting area, so like a generalized cutaneous highs, for example. If it's cutaneous only, the 16-year kind of cutoff, under 16 years of age, they probably don't have a risk of anaphylaxis greater than the general population. But over 16, they should be offered immunotherapy, even if they only have cutaneous symptoms. All right, and so I think that's really important for us to think about here. Now, what is immunotherapy not indicated for yet? Well, we have some investigational research studies looking that can we also modify the natural history of food allergy, right? We're dialing it back. There's some evidence to suggest that early introduction of allergenic foods could prevent development of food allergy later. This was kind of based on evidence that the lowest incidence of peanut allergy in the world is in Israel. And because in Israel, what they do is they give their infants little peanut puffs called bamba. And so, I think the incidence was like 0.7% or something like that. So there is actually a trial in the UK called the LEAP study where they're actually giving these infants this peanut snack and see if we can modify the natural history. This is kind of coming in traction. We won't have that data for a while. The other one is chronic urticaria, which I'll get to a little bit later. So who are the ones we probably take pause about giving allergy shots? Well, I think there's a couple things to worry about, and I will show you the data on this. The first one is uncontrolled severe asthma. And because, let's face it, if we are giving patients immunotherapy, if we're giving them an allergen injection, they are allergic to what we're giving them. So we are trying to give it in a way that we are minimizing reactions, but they've kind of retrospective data looking at patients who've had the worst outcomes on immunotherapy. Uncontrolled asthma was one of those risk factors. Now, since we are giving allergic therapy, there are certain medications that can exacerbate reactions or make them difficult to treat. So as you can imagine, beta blocker therapy will blunt the response to emergency doses of epinephrine. And so most allergists are very reluctant to give allergen immunotherapy to patients on beta blockers. The only exception I can think of is Hymenoptera, because you're doing a risk-benefit analysis, and if the patient's going to die of insect allergy, you might as well do your best to at least protect them from that. ACE inhibitors are also sometimes cautioned against because they can exacerbate angioedema reactions. And then, of course, if you have a patient who's having pregnancy planning, we don't want to have an anaphylactic reaction earlier in conception, that sort of thing. So usually these patients are kind of kept on the same dose. And you can have some benefit even though you don't reach the maintenance, kind of the evidence-based target dose. I apologize. Anyways, so the immunology of allergic disease, I'm going to show you one slide, and then you did my fellowship, you could pass the boards, you know everything, right? Actually, Tao already did it. So you're going to do it, and you're going to be even better at it, right? Okay, so basically, as Tao mentioned, there's a kind of a relationship between the T cell side and the B cell side, right? So we have T cells with a specific T cell receptor that recognizes whatever allergen. Let's say it's peanut, right? And when this T cell was educated, when it was initially presented the antigen, it was told to do an allergic response, not a worm, like a worm type response, not like the traditional bacterial response, right? So when it meets its partner, a B cell, which meets the same guy, and they talk to each other, because this is a T cell primed to fight worms, which we call like a Th2 type T cell, it's going to tell this B cell to make IgE. It's not going to say make IgG, it's going to say make IgE. And so this is where we get into problems, right? Because this IgE is starting to get cranked out like gangbusters. That B cell is going to be converted into a plasma cell. You're going to start cranking out peanut-specific IgE or whatever, right? So what happens is that we have mast cells that have a receptor against IgE, and basically that IgE is just going to be bristling on the surface of that mast cell. And you're going to consider this mast cell a loaded gun, all right? This is a loaded gun looking for peanut. So when you expose the patient to peanut, the gun goes off. And basically, you get a degranulation event, and you release all sorts of good stuff. And I'll get back to this later, but it has multiple system effects, affecting multiple organ systems, depending on the location of the reaction, where the exposure was, etc. All right? And so what is immunotherapy trying to do? Well, we are trying to blunt that response, and it works on different arms. So the first thing is, let's get back to the origin of the problem, which is the B cells and the T cells, all right? So what we can do is that we can make cytokines that actually blunt the inflammatory response. We can kind of tell these T cells to kind of, back off a little bit. We can actually tell B cells not to be activated much, and they're going to reduce the amount of IgEs floating around and the amount of IgE that's bristling on mast cells. In addition, you can tell the immune system to make different types of antibodies. So there's evidence to suggest that if the T cell tells the B cell to make IgG4, for example, you can actually kind of intercept the pass before the allergen hits the mast cell. I'm not going to get into everything, but these are, there's kind of multiple effects, and you can't really simplify it into one sense. But what we're really, in the big picture, trying to do is we're trying to remove that worm-like response and do more of an allergic or kind of like a regular response where this allergen passes through and the immune system just basically ignores it. So, Tao talked a little bit about testing. So this is our standard testing sheet. So basically, we would kind of check off what we want to test the patient to. We'd record the reaction here, and based on this, we would make a prescription here. And so we'd put a certain amount of tree or grass or whatever we're doing. We got about 5 ml vial, and so we got to kind of fit everything in. A lot of our patients require 2 vials to get where they need to be. And then, like I said, we fill the rest of it with diluent, all right? And so, the vials look like this. So the prescription goes into the red vial. That is what we consider the maintenance dose. That's the target dose we know in previous studies that if we inject 0.5 mLs of that dose into the arm, that we can achieve effects. And then, like I said, you have to do that for at least 3 years. I showed you that on the PAT study, right? So we take this, then we take about, aliquot of this and do a 1 to 10, a 1 to 10, 1 to 10, and you can go as far as you feel the patient is allergic to. So this is 1 to 1,000. A lot of our patients are 1 to 10,000. Basically, you want to give it safely. So low and slow is the way to go, all right? So, our standard immunotherapy form looks like this. Again, I told you we start at 1 to 10 dilutions. Or 4, I'm sorry. So 1 to 10,000, right? And so you just start at the ground level. You give 0.05 ml, and then you just kind of go up the ladder, all right? And it really is a ladder. So if you miss a dose, you miss 2 weeks, you basically do not progress. And again, our target is to get patients to that 0.5 dose of the 1-to-1, and that's what they need to get for 3 to 5 years to get a long-lasting benefit that I mentioned to you earlier. Standard Buildup is basically 1 to 3 shots a week. Obviously, the more shots you can do in a week, the faster you go up the ladder. Makes sense. So if you did it once a week, what is this, 5 vials at 10 shots a vial. If you do it once a week, that's 50 weeks. You want to probably want to move it along. You can get benefit at lower doses, but you really want them to hit the target dose. Now, there are different ways to skin a cat. You can actually bring the patient and do multiple shots on the same weekly visit. You could basically do the entire build-up on a day. Obviously, you can imagine there'd be more reaction to that, so they have to be pre-medicated. But imagine, here's our patient who we know at any time she could get another sting and have another anaphylactic reaction. A lot of patients who do have kind of severe insect allergy do qualify or are encouraged to do more of a rush protocol just because of the implications of them getting that second hit. And again, I mentioned some of the evidence for long-term benefit. I showed you the PAT study that showed some benefit after 10 years. So what is our pre-shot assessment, right? So when we have the patient come in, we want to make sure that they're not having reactions. And so we have this 30-minute waiting period because statistically the most reactions to immunotherapy occur within the first 30 minutes. But that doesn't mean the patient walked out and probably had hives, somebody didn't tell you. And you really need to know that because it's something that, if it gets worse the next time and they're not in a doctor's office, this could be potentially bad. That might be the patient who requires epinephrine if we decide to continue with shots in this patient. Generally, we don't give the patients give shots to patients who are ill, probably fever of 100 degrees Fahrenheit or greater. I think it lowers their threshold for reaction. Also can be very confusing. The third thing is I mentioned the concern we have over beta blockers, ACE inhibitors, things that are going to make the reaction worse. And of course, asthma. And like I said, I'm going to talk about this a little later. Giving a shot is pretty easy, basically, just giving the fatty part in the back of the arm. That's not a big deal. So what can we do to make this as safe as possible? And again, the allergists, a lot of patients get their allergy shots in the primary care offices. And so, a lot of my job, I've been trying to go to some of the clinics to do in-services to kind of make sure we're doing this the safe way as possible. There's a partnership between allergists and you guys. And so, what we want to do is we want to make sure we're doing a great assessment, that we're very careful about asthma, right? And that we shouldn't give that injection if there's any concern about port control for asthma. We should adjust the dose based on what symptoms they're getting. I'll talk about reactions later. And then this is the thing I really want to emphasize, that most reactions occur within 30 minutes. A lot of patients do not want to wait 30 minutes. And some patients, some offices, including our office, we do have them sign against medical advice if they decide to leave before that period. And I really feel that this is depending on the goal you're doing. If we're just trying to save them from taking Claritin every day because that's their goal, that's a different thing. Considering the possible risks for that. So like I said, we want to make sure we're doing this in the safest way as possible. Certainly you want to educate your patients on signs of an allergic reaction, which we do. And then of course another contributor to serious reactions are errors in dosing, giving the wrong vial, giving the wrong dose, that sort of thing. So documentation and meticulousness will make sure that this patient breezes through all the doses, all right? So we're giving something they're allergic to, so they're going to react. I mean, it's going to happen. It's probably as high as 80% in some of the retrospective studies. But what type of reactions am I talking about? Most of them are very minor. Itching, local erythema. Those mast cells are going off. I mean, there's IgE in there. We haven't gotten to the max dose yet. So, one of the questions your patients might ask you, well, I reacted, does that mean I'm going to have a systemic at the next dose or the next dose? Is this being safe? And they've done prospective studies, and having a local reaction on one shot does not predict what happens in the next shot. There's no correlation between local reaction on one visit and a reaction on the next visit. Now, for moderate reactions, we want to make sure patients are as comfortable as possible. And so, once we get into like quarter, 50-cent piece, and they got a welt that lasts there for like a whole week or something like that, we got to make sure, like I said, that they're able to tolerate these shots. So some things we can do is sometimes we tell them to take an antihistamine the day of the shot. Certainly local ice pack application after shot to kind of reduce the chance of a welt can happen. We might want to repeat the dose, we might want to step down, and certainly anything that's larger than 4 centimeters, we're going to drop that dose. We might have to hold it there. We might have to really think about it. We're going to continue with this sort of thing. We can't have the patient have a humongous arm for the whole week, all right? Systemics. Okay, so systemics is what we're concerned about the most. Multiple kind of surveys have been done from allergists. I think the most I don't know if there's one that's more recent than 2006, but basically the kind of the range is maybe like 0.01 to 0.3, depending on what study you read, of injections. All right, and when we talk about near fatal reactions, it's probably more on the range of 5 per million injections. At least that was based on the 2006 survey. Now, the two risk factors that correlated with a near-fatal reaction is, number one, occurring at the height of the pollen season, right? So you're already kind of revved up, right? And the other one is dosing error. So again, meticulous documentation. The second thing is that in terms of fatal reactions, the biggest risk factor, again, is poorly controlled asthma. So therefore, a very meticulous asthma assessment, peak flow monitoring is very encouraged prior to giving a shot, just because we know what happens. We have a lot of, we've learned a lot by kind of assessing the data on these shots. Now, on the horizon is sublingual, all right? So, in Europe, about 45% of immunotherapy is actually given orally. You basically stick it under the tongue. You can buy these grass tabs or whatever. And even though like I said, in the United States it's a little different. We do multi-dose therapy, right? I showed you that sheet. We give multiple different allergens. A lot of Europeans, that you can get away with giving a few number of allergens in your immunotherapy. So, like I said, there hasn't been FDA approval in the United States to give sublingual immunotherapy, though some practitioners have been giving it off-label. I've seen it given by ENT folks and that sort of thing. I don't know what Tal's experience has been. But, at this point, I think the barrier of entry is that right now a lot of allergists want to see how the FDA responds to some of these things. Certainly, if you talk about the same issues with subcutaneous allergy shots, there is also local reactions. Of course, it'd be more oral itching, right, local to where you're getting the tablet underneath the tongue here. Some edema, and then there has been anaphylaxis to SLIT, although a lot of these patients couldn't tolerate the shots either, so maybe they're just not good immunotherapy candidates in general. But generally, SLIT is also thought to be safe and effective, though the jury is still out on multi-allergen immunotherapy for SLIT. Maybe, like I said, single allergen has been kind of the bulk of evidence for this type of therapy. So, what do I want you to take out from this talk? So the first thing is who gets shots. And, we talked about allergic rhinitis and allergic asthma, but I don't want you to forget about insect venom hypersensitivity because, yes, patients do have problems with asthma and allergic rhinitis, but really this is the one thing where we can actually save their life by actually desensitize them to a potentially fatal exposure. Okay, and the second thing is that we want to, if we're going to choose glucoside immunotherapy, let's make sure we're choosing the right patients. We might want to take pause on patients who have uncontrolled asthma, beta blockers, patients who are considered to be getting pregnant. And then again, I want to emphasize that one more time, the 30-minute waiting period, that's where the majority of reactions occur. So, in the pipeline will be sublingual, it will be coming. I think it would be, no one wants to get stuck. I think those would be great. We just have to follow how the FDA reacts to some of the data that's been coming out and some of the own trials that have been done in the United States, which are ongoing. So, just some last things, there is a grading system immunotherapy, but I don't want to give it away because I'm talking about anaphylaxis in a little bit. So I'll just take a pause for questions.
Any questions? I've heard of important medications that desensitize patients, maybe allopurinol or aspirin. Do you have any experience with that?
So that's a great. I'm really glad you brought it up. So there's kind of like two different kind of how the allergist kind of approaches induction of tolerance. All right, and so what I'm talking about here is kind of modifying the immune system so you are no longer allergic to that exposure. All right. So I showed you some of the mechanisms, how we're like reducing IgE and that sort of thing. Now, when we get into the arena of drug allergy, so I'm not sure how many of you have seen like a drug desensitization before, that sort of thing. Usually, our goal is not to modify the immune system to induce long existing tolerance. Basically, after the patient stops taking the drug after desensitization, they are still allergic. They are still considered allergic. Now, again, we are not exactly sure what the mechanism of drug desensitization is, but like I said, I really want to kind of separate those things into two categories. Allergy immunotherapy is a modification of the immune system. Drug desensitization is an induction of tolerance, so you can, while you get them to the top dose and they still have the blood level of the dose in their body, they can tolerate the drug. But as soon as that blood level drops, those mast cells reload, and they're ready to go the next time you give that drug. It is not a long-lasting modification. Anything else? That's a great question.